This week on the BackTable podcast.
These checkpoint inhibitors are not nothing. We talk about them like they're very easy. And in fact, many of my patients do extremely well. They're out 70, 80 years old, doing great, doing sports. I live in San Diego. They're all playing pickleball every day. They're doing great. But that 20% of patients who have a significant side effects, I mean, they can be severe. And if you don't know what you're looking for like that, that's a big deal too. And if you are willy-nilly combining it with another agent without proving that the combination is better than the single agent, we are doing a disservice to patients.
Welcome to BackTable. I'm Bogdana Schmidt. I'm a urologic oncologist at the University of Utah, and it is my absolute pleasure to have with me today Dr. Tyler Stewart from University of California, San Diego, who is a wonderful medical oncologist. I know we haven't worked together before. I had to Google you. What's harder, performing with your band at BCAN or trying to convince urologists to use systemic therapy in non-muscle invasive bladder cancer?
Bogdan, it's an absolute pleasure to be at BackTable today to discuss systemic therapy for non-muscle invasive bladder cancer. And I'm just thrilled to talk to a urology audience and give the medical oncology standpoint. The performing at BCAN is certainly harder. I think that chatting with urologists about systemic therapy for bladder cancer, no problem, especially in this day and age. The folks that I work with, they're my best buds. And so that's no problem. Standing in front of my peers and having a good time on stage and singing a few numbers, that probably gets the heart rate going a little bit more.
What did you start with? What was the leading number there?
I think that we usually start with Start Me Up. It's a Rolling Stones song. Yeah. And so that's probably our go-to. It has a nice vibe as a first song. Absolutely.
Well, let's start this up. Let's go. So what do you think is the role of a medical oncologist in what a lot of us have traditionally considered a surgical disease?
First off, thank you so much for having me.
I'm super excited to have you here. I think this is going to be a really great conversation.
I've been practicing at UC San Diego as a medical oncologist that focuses on GU malignancies, and a large portion of my practice and my academic research is all in bladder cancer. You know, I talk with urologists who have been there for a number of years, even before I was there, and they talk about bladder cancer as being a urologist's field. And that's just not the case anymore. Now it is really a team sport for bladder cancer. In the muscle invasive space, certainly, but increasingly in the non-muscle invasive space and even in the advanced space. As our therapies have become so powerful, we are dealing with patients who have metastatic disease, who still have local complications. And so I think that the role of the medical oncologists, urologists, and even radiation oncologists, it's a team sport now.
I completely agree with you. I think the landscape has changed, and I think it's a good thing. It's a good thing for our patients to hear the perspectives that all of us bring to the disease. And it's good that we're able to expand, I think, the role of each individual player, because it just means we have more to offer.
And I think that patients really benefit from having a team of everyone looking at what are my options, what is the best option for me. And so, as a medical oncologist who treats patients with bladder cancer who have, from non-muscle invasive to advanced disease, I'm always there talking with the team about what are the best options for the patients. Today, I think that we're mostly talking about the non-muscle invasive bladder cancer space. And this is a space that, is very interesting for medical oncologists to be in. It wasn't too long ago that we only dealt with, especially those of us who dealt with bladder cancer and patients with more advanced disease, that we were looking at our therapies to treat patients who have incurable diseases. And always when we're thinking about our systemic therapies, we're thinking about what is the risk benefit. And when the risk of metastatic disease is, this patient could pass away from the cancer, what do I have in my back pocket to possibly help this patient live longer, happier, healthier? That is a much different beast than when I have a localized, potentially curable disease. And I'm thinking about what are the consequences and what are the real benefits of my therapy compared to a curative procedure such as cystectomy, especially for patients where that superficial bladder cancer keeps on coming back. I think that it's a different mindset for many of us to be in, and we're happy to participate, but it certainly is a little bit of a shift.
Completely agree, especially when you start thinking about the cumulative lifespan of that patient, right?
Absolutely.
You start to think of it almost the way that we sometimes do for testicular cancer, where you have a younger patient and you're saying, what is going to be the impact of this treatment 10 years from now,
Absolutely.
20 years from now, where unfortunately with metastatic bladder cancer, we're seldom thinking about 20 years from now for these patients. So it's a mind shift for sure. So today in the non-muscle invasive space, which patients are you seeing? Who is being sent to you?
Yeah. So when I'm seeing patients with non-muscle invasive bladder cancer, it is for patients who have BCG-unresponsive disease. And predominantly at our institution, I see patients who have BCG-unresponsive CIS. And that's, of course, because there have been a couple of trials
FDA
looking
approval.
That's right. Looking at systemic therapy with immune checkpoint inhibitors, including pembrolizumab, and actually atezolizumab was also studied. And the Keynote 5.7, which looked at pembrolizumab for patients with non-muscle invasive bladder cancer, looked at it actually in both for patients with CIS and for patients with Ta/T1 high-grade disease without CIS. And the original FDA approval was because at 3 months, when patients took pembrolizumab, we saw a complete response of around 40%. That being said, at 24 months, those numbers look like 20% or so. And as you go even further, those numbers look like 10% maybe out for a couple of years.
Yeah, they're disappointing.
Yeah, that might be how I phrase it as well, because when we talk about these in our multi-deep bladder clinics, for patients who have BCG-unresponsive CIS, we always talk about pembrolizumab as an option. But I think that we look at the data and we say that those data are disappointing. And although pembrolizumab is FDA approved and there is data to suggest that some patients may benefit, it is impossible to see which patients are most likely to benefit. And now as we have more agents that are quite effective and probably without the systemic toxicity, I think that our group and most groups, I think, are preferring those localized treatments rather than systemic checkpoint inhibitors.
So intravesical therapies approved in the space. Yeah, I think that's very similar to how a lot of us are seeing it at our institutions as well. What about neoadjuvant therapies for T1 disease or variant histologies? Are you seeing those patients, or do you want to be seeing those patients? How's that?
Right now, our group and my thoughts about it is that generally we do not see those patients. So if you have no evidence of muscle invasive disease or lymph node spread, then if you have only T1 or less and you're thinking about a curative cystectomy, those are patients who are going to go on to curative cystectomy, and then we'll look at the pathology and make decisions about if there's any role for adjuvant treatment. But as of right now, I see no role for perioperative systemic therapy for T1, even if there are variant histologies, save for few of them, which
Plasmacytoid?
Even plasmacytoid, I wouldn't give perioperative systemic therapy. But if you had small cell, so if you have T1 small cell disease, our institution would probably give that person, platinum etoposide for a number of cycles and then think about curative surgery. That would, of course, be a big old tumor board and a lot of people looking in, but we would be more aggressive about that. But T1 of other variant histologies, we'd probably just, if the plan was to take the bladder out, we'd probably take the bladder out and look at the pathology on the back end.
Let's see. Yeah, that's basically how we practice too. Even when I ask for it sometimes, where you have a bigger tumor, aggressive histology, kind of these concerns about tumor location occasionally, and generally we'll go to cystectomy and then talk about adjuvant therapy.
Yeah. I think the data just isn't there for a lot of these T1, even variant histologies, and I think that there's still a role for adjuvant therapy, adjuvant chemotherapy, adjuvant checkpoint inhibitors. And so that's probably how we would practice.
So in that scenario, for example, let's say it was T1 on TURBT.
Yeah.
You take out the bladder and it's T2.
Yeah.
And node negative, margin negative. Do you always go to cisplatin-based chemo if the patient can tolerate it?
Yeah. So great question. Man, we're getting into this. Like, what am I doing?
This is what you're here for. I want everybody to learn from you.
In general, if somebody has PT2 disease after surgery, we probably watch those patients generally, and we generally don't offer systemic therapy either with chemotherapy or an immune checkpoint inhibitor. But if you have PT3 disease or lymph node positive, then we would offer systemic therapy. And our institution, my preference is to consider chemotherapy with a cisplatin-containing regimen first. And then if they're not eligible for that, then I would consider an immune checkpoint inhibitor. We don't generally give a combination. We don't do a Niagara in the adjuvant setting, and we don't do a combination. Just no data in there, so I'd probably just do chemo if they're eligible. We do, for patients who have muscle-invasive disease and undergo cystectomy, we have been checking ctDNA assays looking for evidence of minimal residual disease. There are lots of these assays that are out and about.
Yeah.
And we can talk about this at different times, but these assays we use to help kind of guide our therapies somewhat, but the data has not proven that treating based on ctDNA is actually beneficial to the patient. So there are ongoing studies looking at this, but it might guide how I surveil the patient, but probably not my treatment.
I think it's really interesting thinking about, are we using these basically prognostically, or are we using this to help guide treatment for patients? So Laura Bukovina at Cleveland Clinic actually just published using Natera in the non-muscle invasive space and showed that for some patients it did change her management, or these patients did harbor more aggressive disease. And we know from the muscle invasive landscape, right, that these assays can predict recurrence sooner than we'll see it on imaging, like from tombola. So I wonder, for myself, should I be sending it? I haven't transitioned to sending it on everybody yet, but I'm thinking of sending it on T1s now, and I haven't been until now.
I think the space is wide open, and it wouldn't change my management as of right now. But if your ctDNA when one of these ultrasensitive tests is positive after you've had a definitive cystectomy, that portends that's bad news.
There's something going on there.
Yeah.
Yeah, I agree. But you also would expect that to never happen in non-muscle invasive disease, right?
You would hope that it doesn't happen.
But at the same time, we know some of these patients who will develop node-positive disease. It's a small percentage who only have a non-muscle invasive diagnosis, or maybe the TUR just didn't get to the depth of it.
If you still have the intact bladder, I get concerned that some of that ctDNA is shedding from the tumor inside the bladder. And then if you're treating patients based on ctDNA and giving them systemic therapy when they have no known muscle invasive or metastatic spread, you could be over-treating those patients, and God forbid they have a bad outcome and they only had superficial disease. It's not my practice as of right now. More to come, I'm sure, in the years to come.
No, I agree with you. I think that absolutely we shouldn't be over-treating patients. We're talking about minimizing over-treatment in every other landscape. We shouldn't be escalating it, especially without evidence. But to get back to where you're saying there's no data for using it in T1 patients, do you think that we should be trying to get that data? Do you think we should be designing trials specifically looking at that question in the T1 space, or no?
Absolutely. And for everyone who's listening to this, right now we talk about ctDNA as this great assay. ctDNA is great. I love talking about it. I think it's the future of many cancers, including bladder cancers. But what we're talking about is a biomarker that is evidence of residual disease in the body. And what you really want to say is there a biomarker that shows that there is disease outside of the bladder? And do we have a biomarker that can prognosticate that patients will develop metastatic disease if we were to move forward with a cystectomy? And so as those biomarkers get developed, I absolutely think they should be investigated for muscle-invasive disease, post-cystectomy, and then even for non-muscle invasive disease. If I had a biomarker where even though the patient had non-muscle invasive disease, but I knew that there was disease outside the bladder, I'm changing
it changes the game.
Changing the game.
Yeah.
So all those companies working on that,
keep working on it.
And love to see those studies.
No, I absolutely agree with that. But getting back to
the pembrolizumab. So generally speaking, I'm only using pembrolizumab in patients with non-muscle invasive bladder cancer with CIS. So BCG-Unresponsive, CIS, essentially if they're not responding to those other therapies, if we've decided that this might be the best option for the patient. Whenever we're thinking about pembrolizumab in this setting, at least for my group, we've really looked at some of those other intravesical agents that are already FDA approved. And we should really remember that cystectomy is a great treatment option for non-muscle invasive bladder cancer as well. And I get very nervous. We all get, I'm sure you get nervous as well. We all get very nervous about missing a therapeutic window where we're trying all these agents, and next thing you know, this patient has meted out and we've lost our curative window. So if we're doing 3-4 different intravesical agents, we're talking about systemic pembrolizumab. Let's look at all the options.
Else. Yeah. No, I hear exactly what you're saying. I think that this is really an evolving landscape for us too, because getting comfortable with using more than one line of salvage therapy is something that we're all exploring right now, right? Patients obviously historically have, and a lot of survey data have said, we want to keep our bladders. But we have the cysto data that was just presented at AUA that is very compelling that patients with cystectomy do well in many factors, do better than patients who went the bladder sparing route. So I think having that information for our patients will also be super important.
When I saw the cysto data, I think it's a little bit of a game changer, a little bit of a mental switch, because when patients come to me and they talk to me about what their wants are, nobody wants to lose their bladder. But some of the data that from cysto suggested that quality of life better for patients who are getting cystectomy. So it's a very interesting piece of information.
Absolutely. And I think we'll really have to figure out how we balance that in line with some of the other treatments that we have. We've had cystectomy as the gold standard for a long time. I still think it belongs on that board. But if we have maybe treatments that are less disappointing, then certainly we can always push it back. I think that's the idea for a lot of our patients is, can we delay cystectomy longer?
And this is absolutely not my realm to really speak intelligently about, but there are different surgical techniques. And I do think that neobladders have really shifted some patients' perceptions of having cystectomy. And I think that offers a very nice option for the appropriate patients as well. So
yeah, absolutely.
And here's a medical oncologist talking about a neobladder.
Well, here's a urologist talking about medical oncology. Yeah. This is what we do. We've certainly had neobladders in the news recently with Deion Sanders having undergone surgery for what we think is maybe non-muscle invasive disease. I don't speculate on anyone's particular medical care, nor do I think we should. But I think it's good to have that out in the media, to have other patients see it, hear about it, have it as a conversation. Because the way that so many people wear, the pink breast cancer ribbon or talk about prostate cancer, we just haven't had that same
that's
exposure
right.
for bladder. Patients kind of shy away from talking about it. They think it's personal, private, shameful maybe. And I really am encouraged that we're having more of a conversation with bladder cancer. I think it's going to benefit our patients to have it out in the open like this.
That is very well said.
Let's talk about some other things then.
Great.
So let's talk about things outside of pembro in this space. So we touched a little bit about using it in combination with things that we certainly do in the more advanced disease state. What do you think about combination therapies in the non-muscle invasive space? Should we be trying to add something intravesical and something systemic together to try and decrease the number of patients who progress down the line? Okay. What's the trade-off?
This is classic medical oncology. So if A works and if B works, what about A plus B?
Sure.
And so I think these studies are great. So we were involved in the core trial. The core trial was CG-0070. I think it goes by cretostimogene now.
Cretostimogene.
Thanks very much. And this was combined with pembrolizumab. And this study looked great. I think that the CR rates were, I actually can't remember. And then 12-month CR rates were something like 57%. Yeah. And
about 54% at 24 months, I think.
Yeah. So, and we have patients on this who've done very, very well. Does that combination actually do better than CG-007 by itself? I don't know. So the the Bond 3 study that came out as well, those numbers also looked very good. I think high 40s at 12 months. So the truth is that I think that there could be a role for a checkpoint inhibitor in combination with a lot of these intravesical agents. But you're going to have to prove it to me that the combination is actually better than the single agent or the single agent sequenced with a checkpoint inhibitor. Because in the studies, in every one of these studies, about 13 to 17% of patients are having grade 3, 4 adverse events, and those can be permanent. These checkpoint inhibitors are not nothing. We talk about them like they're very easy. And in fact, many of my patients do extremely well. They're out 70, 80 years old, doing great, doing sports. I live in San Diego. They're all playing pickleball every day. They're doing great. But that 20% of patients who have a significant side effects, I mean, they can be severe. And if you don't know what you're looking for like that, that's a big deal too. And if you are willy-nilly combining it with another agent without proving that the combination is better than the single agent, we are doing a disservice to patients.
So I agree with you wholeheartedly, but I want to push you just a little further to talk about CREST.
Yeah, great. I love to talk about CREST. We were actually also involved in CREST. I was actually my site PI. What are we doing? Having medical oncologists as site PIs for non-muscle invasive bladder cancer studies.
I disagree. If sasanlimab is part of it, you need at least a co-PI to be a medical oncologist.
That's absolutely right. I absolutely agree with that. So the CREST study, a large phase 3 study looking at the role of adding a checkpoint inhibitor with BCG. So in this study, 3-arm study, the standard of care was BCG induction and maintenance. And then there were 2 investigational arms. One of them was BCG induction and maintenance with sasanlimab. That's Pfizer's anti-PD therapy, which can actually be given as a intramuscular sub-Q. That's right. It's given sub-Q as opposed to an IV, which is nice. And then the other arm was the same thing, except it was BCG induction, no maintenance. Primary results have been announced. I think they were at AUA first, and then Tom Powell's updated, maybe gave some other results at ASCO this year. I think that the primary results looked at 2 years, the event-free survival rates were something like 85 versus 80%. So the hazard ratio there was something like 0.7, which looks great. But the actual event-free survival, if you look at 24 and 36 months, was something like 85 versus 80%, and then maybe by 3 years, it's a 7% difference.
So the delta was small.
The delta is small. The hazard ratio looks great.
Yeah. That's because BCG works.
But
if you do BCG
works
with maintenance, it works.
Yeah.
Now, I think it was good proof to show that BCG without maintenance is substandard, and that's the challenge, unfortunately, sometimes is getting a patient through all of BCG with appropriate maintenance, which we know is effective, whether it's because of shortages or because of patient factors, not wanting to continue with the more intensive therapies, having bladder-specific issues. And we saw that all across the arms, that just getting a patient completely through all of this is not easy for our patients.
Yeah, I can completely see that intravesical therapy comes with a lot of side effects. But if the question is, do I look at that data and think, is this going to change my standard of care? I don't know. I guess from a urologist standpoint, I'd be curious to know if you look at the data and think that all of a sudden, I'm going to send this patient to a medical oncologist.
So I will tell you, when I was asked before the data was presented, what is the delta you need to see? Because that's basically how I phrased the question to, when they're saying, well, is this going to change the game? Is it not? And I said, it all depends on what the delta is. If the benefit is significant enough, then I think a lot of us are going to bite the bullet and say this is worth it.
Sure.
But it has to be significant enough. And for me, the mental number I had in my head was about 15%. I said, if it's at 15%, I'm going to think about it.
Yeah.
Maybe not for every patient, but certainly for some. Yeah. And it didn't meet my personal benchmark, which I tried to set for myself before I saw the data. Yeah. But I don't think it's a game changer as a urologist. I'll wait to see the long-term data to see if it's more convincing, if there really is an effect further down the line, maybe 5-year data, cystectomy-free survival in that population.
Yeah.
I want to see it, but I'm not convinced yet.
I absolutely agree. I don't look at that data and think that it's changing my standard of care. I'm happy to chat with patients about it. If it gets FDA approved and we feel good about it, but I don't think that I am offering that to patients based on the study. The interesting thing about that is that I think that there are probably going to be some subsets that look very good. I think you're going to find maybe the T1 plus CIS.
The very high-grade patients.
Very high risk, very high grade. Those patients, we might say, wow, there's a stark difference there. I haven't seen all of that data. I think that when Tom showed some of the data, he actually talked about, well, the patients with TA plus or minus CIS, the hazard ratio there was only around 0.9 or so, whereas if you had T1 plus or minus CIS, or if you had CIS, there was more of a stark benefit. The hazard ratios were improved, but I'd like to see that data a little bit more. The other thing is this the outcome that we most care about?
Yeah.
Recurrence of their high-grade disease versus...
Thank you for saying that. I agree. Yes, of course, recurrences are annoying. Yes, of course, recurrences require trips to the operating room, time off, financial toxicities. All of those things are very real. But when I'm talking to a patient, they care about, are they going to be alive?
Yeah.
Are they going to still have their bladder? Yeah. And how many times they need to see me, and how can we make it fewer times, right? And so that's number 3 on their list. The recurrences are never number 1. So I agree with you. I'm not sure that that's the primary benchmark. Now it's a nice plot, it's a nice graph, it's a nice way to show the data, to show what your treatment is doing, but it's not the right question.
Yeah, I totally agree with you. I don't think that, once again, I remain skeptical about checkpoint inhibitors in the non-muscle invasive space. I am skeptical in the BCG-Unresponsive. I am definitely skeptical in the treatment-naive space.
So let's get into the details of what makes you skeptical, which I'm sure is the adverse event profiles, right? It's what the patients have to deal with for the measurable benefit, smaller measurable benefit of these treatments. So I'm worried as a urologist that with greater uptake of these drugs, there are going to be urology groups who feel pressured to offer these treatments on their own without maybe a medical oncology partner, or without a medical oncologist leading this. Now, of course, if it's an infusion, that's a little bit different, but now that they're talking about sub-Q, right, sasanlimab, we're used to giving sub-Q things in our clinic, even other administrations that are easier to workflow. I think urologists can offer this in their clinic. What I'm worried about is the phone calls that can come, right? So our urology nurses are very, very comfortable triaging patient calling about hematuria. They know to ask, is it ketchup? Can you see through it, right? We know the questions. When a patient comes in and says, so my elbow's itchy, and they're calling and saying, hey, my elbow's been itchy for a couple of days.
Yeah.
I'm not sure what level of training and how long it'll take the average urology practice to have the gut check response not be put some Vaseline on it, right? And how is that going to impact the patient experience?
Man, this is such a good question, and I feel pretty strongly what I'm about to say is that if you're going to have a practice that gives checkpoint inhibitors, you've got to have somebody who is an expert at giving checkpoint inhibitors and treating the potential side effects. And if you don't have an expert in the practice, in the clinic that is giving these drugs, you shouldn't be giving it.
Patients will suffer.
Patients will suffer. And you know, it's really interesting because giving the drugs is easy. And if a patient is clearly doing poorly, yes, you know, you send those patients to the hospital. But many times what we do is we try to prevent those patients from getting very sick, and recognizing the early signs of IO toxicity is hard. You know, before I came to San Diego, I did my training over at Yale, and Yale was one of the early institutions about doing checkpoint inhibitors. And so when these were coming out, we had no idea what we were doing. And people were having side effects, and you make so many mistakes and you don't know these are new. But now we go through significant training, and we as med-oncs, this happens to have been in our wheelhouse. Now, do I think that you need to be a medical oncologist? I mean, what you need is to have expert training in it. And so if you have years of giving these IO therapies in one setting or another, I mean, okay. But if you don't have somebody who has given this time and time again and dealt with many of the toxicities, that drug should not be given in your practice. That's what I'd say about that.
No, I think that's a very valid viewpoint, and I share it, and I think many people do, and certainly have that same amount of caution. And I think this caution is deserved, right? A lot of the toxicities we saw, even with pembrolizumab, were more severe than what we're seeing now. And that's not because the drug has changed. It's because we've gotten better at recognizing them and triaging them and preventing the severe toxicities. I don't want urology to go backwards and recreate that wheel. I want people to enter on the new level of experience in the way that patients don't have to suffer those consequences.
Yeah, I totally agree with that. And the side effects are challenging to deal with, and patients can have subtle complications, and you question, if you come in, you have a bout of diarrhea, is that the immune checkpoint inhibitor? And we get very comfortable at triaging these as, what are potentials, what are not, what should we rule out? And just once again, I feel that you have to have somebody who is an expert at giving these. And if urology practices want to give these, then hire a med-onc in the practice to do that as well, or partner with a medical oncology practice to have your go-to person for these drugs. But without expertise, patients are gonna suffer.
So I know you can't distill your expertise for our audience, in a few minutes. I don't ask that of you. But if you can talk us through the way that you as a medical oncologist, when you start somebody on a checkpoint inhibitor, what baseline labs do you get? How frequently do you monitor? Because it's not a trial situation anymore. And what advice do you give your nurses, call lines, whoever's taking the phone calls?
Bogdana, I'm even a little bit hesitant to answer this question because this question kind of sounds like, all right, but let's say if somebody who didn't have expertise were doing it, could you caution them to do it? And I just say once again, don't do it. Don't do it. Just make sure that somebody who has expertise does it. I think it's just going to be better for the patients. To answer the question, we generally check a CBC and a CMP and then a TSH, T4, cortisol, and then monitor those serially every 3-6 weeks, or depending on how often the drug is given. But the labs are kind of the least of the things. It's really having the ability to triage sick calls and letting patients know. And the truth is that I go through a list of things that are commonly seen, but I also let patients know that these drugs can literally do anything. And I have seen, you name an organ and I've seen it, including CNS and cardiac toxicity and pneumonitis and kidneys, and trying to differentiate, does my patient with bladder cancer have nephritis versus are they obstructed? You got to start thinking about all your options. But what I might say is that having the resources to triage and having the expertise to triage some of those calls is more important than getting the labs and talking to the patients. You warn the patients about all the toxicities, and then you just tell them, if you're having something, you call, and you rely on your team to be able to triage. Is this something worrisome? Is it not? How should we go down that workup?
No, I agree with what you're saying. I think for me, because I don't have that comfort with these drugs, and certainly I share patients who are getting these treatments in the muscle invasive space, let's say in the adjuvant setting, right? Or my adjuvant kidney patients will sometimes get pembrolizumab. And when a patient knows me and knows their medical oncologist, but they don't know which one of us to call sometimes, right? And they'll call me because they've known me longer and they just met the medical oncologist 6 weeks ago, right, when they started this new treatment. And so we'll get these phone calls. And basically what I have told my nurses is you cannot blow off anything, nothing. You don't know how serious this is. Treat it as if it could be. Make sure you escalate it up the chain right away. Err on the side of having the patient be evaluated, having the patient be seen, because I have that personal discomfort of I haven't managed these side effects for 3 years. And so I'm terrified that this could be nothing, but it could be somebody's kidneys shutting down at home. Right?
Exactly. Yeah, I would suggest to your team to just have good relationships with the medical team, which I'm sure that you do, and just passing those triage calls over there and just highlighting, hey, listen, they called in with these. I don't think this is from my surgery. It's just, can you take a look into this? And then I think the medical oncology team should probably champion those.
Yeah, I think that's an important takeaway for everybody listening about this, because this is a really great space for us to work together, right? This isn't this space where urologists should be trying to reinventing the wheel?
Once again, I think that it all just goes to that bladder cancer, including upper tract disease as well, really all a team sport now. I mean, the patients benefit. I really truly feel that patients benefit from having a surgeon and a med onc, sometimes a rad onc as well, that really knows their case well, and that team works to provide the best care for the patient. And so when it comes to managing toxicities, when it comes to dealing with complications for their disease, I think we as a team, the patient doesn't know. The patient, sometimes it's hard for us to know. The patient's not going to know who to call. Sometimes they just know I should call somebody, and having a team that is able to navigate that on our end is probably the most important thing.
Absolutely. I agree with that wholeheartedly. So speaking of this partnership, right, that we're developing. So I think we're all across all of our practices really trying to figure out how we're going to incorporate this into the non-muscle invasive landscape. Certainly up until now, even up to now, right, our options with pembrolizumab alone have not shifted the landscape of the relationship. I would say that, right? Most non-muscle invasive disease is still being handled by urologists, with the occasional rare involvement of the medical oncologist for patients who maybe can't tolerate an intravesical therapy, but also can't get a cystectomy. And so you're sort of stuck in this rock hard place. Yeah. What do we do? But outside of that scenario, we're really not interacting too much. And you and I both agree that the CREST data really didn't shift that. I don't think, maybe in some practices you'll see a little bit more involvement, but I don't think it'll be dramatic. Mm-hmm. My question to you is, abstractly thinking, what do you think it would take for non-muscle invasive bladder cancer to become more 50-50? Or do you think we'll never be there because it's a localized disease that has localized treatments?
Well, I think that if you start having systemic therapies, checkpoint inhibitors or not, if you start having systemic therapies that are able to eradicate disease, make people live longer, happier, healthier, and those systemic therapies do better than intravesical therapies in terms of durable responses, potentially cures, I mean, sure. But that delta is going to be pretty significant given that BCG is a pretty effective agent. And I don't know of any systemic therapies that are beating that anytime soon. There has to be a significant delta to make me want to give toxic systemic therapy to patients with localized disease where there are good localized options, and potentially cause long-term serious side effects with systemic therapy when we could cure with surgical techniques. So, I think that the non-muscle invasive space, there is still room to grow for the relationship between a urologist and a medical oncologist. I think the significant steps we've made in terms of advanced disease and muscle invasive disease helps with our relationship.
Yeah, we're going to be talking more about those patients no matter what.
Yeah.
Right.
And so I think if we start having more effective therapies as systemic, and then we try those even for patients who have non-muscle invasive disease, and they're effective and they have, long durable responses, like we're having this conversation again. But for right now, I think checkpoint inhibitors, I remain just skeptical, at least for that specific type of agent in this specific clinical context.
I agree with you. I think that it'll take a change in the landscape that's broader than what we have going on to make that different. Now, if there was a way that we could treat non-muscle invasive disease to effectively eliminate muscle invasive disease, right? Or eliminate metastatic disease. Yeah. Sure. We would all take that. But I'm not convinced that we have a mechanism that to target to do that quite yet.
I don't think that we're there yet today. But as our drugs get better, I think that there could be a day when we are using systemic therapy for non-muscle invasive disease. And I think that there are potential roles for clinical trials looking at that, but not today.
So what are you looking forward to today?
So, actually in the non-muscle invasive space, the other thing that I really like is I like the idea of using biomarkers to evaluate and potentially act on to decrease the number of interventions somebody has inside that bladder. So my group happens to be pretty excited about ctDNA and using it in the blood, but also in the urine. I think that urinary biomarkers have the potential to, in some role, decrease the amount of cystos for surveillance, and also might be able to identify residual disease and might identify patients where you need to escalate or change your therapy, or maybe there's a role for that. I think that's a very exciting time. That doesn't really speak to systemic therapy, but I think that is something that patients would love to have a mechanism where they don't always have to get scoped, or at least not as often. And if we can find accurate biomarkers to do that would be, I think that's a next step for patients.
I think that would be a very well-received step for patients. If you consider the amount of time it takes, we can say that, a cysto takes 2 minutes, but it's not 2 minutes for the patient.
That's
who
right.
had to drive an hour, park for 15 minutes, walk up, do all the things, and then go back to their life and have to do this every 3 months. Yeah. That is a very real commitment. I can't see a doctor every 3 months. I haven't seen one in 3 years, probably.
Yeah. I totally agree. I think that patients would love to be able to, pee into a cup, see if their cancer is back or not. And if that the cup is negative, the urine's negative, the doc calls them up and says, hey, looks great. We'll do this again in 3 months.
Well, speaking of things that are great, this has been a wonderful conversation. Thank you so much. I've learned a ton from you. I know our audience has as well. Any last words you want to leave folks with?
No, Bogdana, this is so fantastic. Thank you so much for inviting me here, and for the BackTable folks for inviting me. This has been just an absolute pleasure, and I'm sure that we'll be working together in the future.
I look forward to it. Thank you so much.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTable Euro on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening, and see you next week.